Okay, welcome everybody to the first Department of Public Health seminar of our spring semester. I'd like to introduce Dr. Ramona Danielson, our speaker for today. Dr. Danielson, sorry, I have to open the door to additional attendees. Dr. Danielson is an assistant professor in the Department of Public Health at Ndsu. She has 21 years of experience in applied social and public health research. Her research interests include health equity, adverse childhood experiences, trauma-informed practices, social determinants of health, life course, and community self-healing. She's a master trainer for ACE Interface in North Dakota. She's here to present on the role of trauma-informed principles in advancing healthy and safe communities today. A reminder, we will have time for questions immediately following Dr. Danielson's presentation. So if you have any questions during the course of the presentation, please feel free to include them in the chat box, and we will get to as many of them as we can immediately following her presentation. I will now turn it over to Dr. Danielson.
Thank you. Welcome, everybody. I'm so pleased to see lots of names that I know and lots of names that I don't know, and I'm excited to have the opportunity to talk to you today about something that I'm very passionate about and that I think is a very important part of public health. I first wanted to give the NDSU land acknowledgement. We officially have a approved land acknowledgement. So we collectively acknowledge that we gather at NDSU, a land grant institution, on the traditional lands of the Osheti-Sakowin, the Dakota, Lakota, Nakota, and Anishinaabe peoples, in addition to many diverse Indigenous peoples still connected to these lands. We honor with gratitude Mother Earth and the Indigenous peoples who have walked with her throughout generations. We will continue to learn how to live in unity with Mother Earth and build strong, mutually beneficial, trusting relationships with Indigenous peoples of our region. The Adverse Childhood Experiences study from the 1990s can be described as one of the biggest public health discoveries of the last century. Along with advances in neuroscience, epigenetics, and resilience, this science can transform the way that we see challenges and solutions in our communities. And in every major public health discovery, the first actions that can save lives are to accurately share the facts and then to take informed action within our own spheres of influence. The learning objectives for my presentation today are to explain the importance of the shift from asking what is wrong with you to what happened to you, to give examples of impacts associated with high adverse childhood experiences with high ACE scores, describe trauma-informed approaches that contribute to healing and resiliency for individuals, families, and communities. I did also want to let you know that the seminar has been approved for 0.15 CEU credits, and I have the link at the end of the presentation for where you go to get those. And I do also have a link to where you will be able to access the recording of this seminar. We each experience a different path in life, but for illustration, I invite you to imagine two worlds. The top world, the malevolent world, is mean and dangerous. The bottom world, the benevolent world, is kind and generous. The bottom path is free from what we call toxic stress. On the top path, children grow up with sustained danger, and the stress hormones and neurotransmitters that are released as a part of their fight, flight, freeze reaction have impacts on their brain development, the functioning of their brain, the mass of their brain. On the top path, brain cells can struggle to develop healthy neural networks, and this is why we call trauma, continuous stress, recurring unpredictable stress, toxic stress. The brain prepares for living in a dangerous world. In this world, characteristics like being hypervigilant and hyperreactive actually help the species survive in dangerous times. In the long run, however, these same characteristics can also lead to cardiovascular disease, mental health challenges, and productivity problems. Advances in neuroscience shed light on why ACEs are so powerful. We're really only made to be under stress for about 20 minutes at a time, long enough for that fight, flight, or freeze response. So experiences that cause our stress chemicals to be continuously produced have a big impact on development. And a growing brain that is exposed to sustained danger, like abuse, neglect, or chaotic relationships, generates predictable patterns of brain architecture, behavior, and traits. But it's important to remember that both brains are adapting to their experience. However, these adaptations can make it so that people who developed on the top path may find it difficult to be successful when they're asked to operate on the bottom path. We shouldn't be afraid of and try to avoid all stress. Stress places demands on our body, being hungry, cold, exercising hard, working on a deadline at work, and our body has stress response capabilities to help us manage our stress and keep it equilibrium. Stress contributes to healthy development and is an essential piece of building resilience. The key factor to whether stress is positive or destructive is the pattern of stress. So here we can talk about the malevolent path again, as represented on the top, where the stress is unpredictable, extreme, or prolonged, and it creates vulnerability to the effects of stress. That benevolent path is represented on the bottom again. Here, stress that has been predictable, moderate, and controllable has contributed to the development of resilience. And as our developing brain keeps forming connections as a child grows, the more an experience is repeated, the stronger the neural connections become. We use the term toxic stress to differentiate the severe, chronic, prolonged, unbuffered stress that is not a normal part of development. And that's differentiated from positive stress and also from tolerable stress, which, depending on whether there is a relationship with a competent person to help buffer that experience, can be positive or tend toward toxic stress. What happens in our lives determines what gets wired into the brain as it develops. Trauma is interacting with processes that are happening naturally. The key is what gets ingrained and what parts are never activated. Babies are born with only the connections and brain functions that they need immediately. Most of the wiring of our brains occurs as the result of life experience from our senses over the coming years. And then by puberty, the least experienced connections start to withdraw. They call this pruning. At this point, children who have experienced that malevolent path have connections wired into their brain based on those experiences, and they have fewer of the connections that are associated with the benevolent path. This is an image showing a PET scan of a normal brain on the left with a high level of brain activity in the temporal lobes of the brain. The temporal lobes are responsible for regulating emotions, and they receive input from our senses. On the right, you can see the temporal lobes of a severely traumatized child, and those lobes are inactive. Children with underdevelopment of this part of the brain suffer severe emotional and cognitive problems, as well as having difficulty in making or sustaining positive relationships. So what is getting wired into the brain during this period of growth of creating neural networks, and then the process that happens around puberty of pruning synapses that are less used? There are many negative effects of childhood abuse and neglect on how the brain develops. We can give 4-hour lectures just on what's basically covered in this slide here. So if you're interested in more about the brain impacts and architecture, that is another conversation. So some of the effects, though, that can potentially happen are too much activity in the amygdala, and that is responsible for processing emotions and determining reactions to potentially stressful or dangerous situations. Can cause a decrease in the size of the hippocampus, which is important in learning and memory. A decrease in the size of the cerebellum, which can affect motor skills and coordination. A decrease in the size of the corpus callosum, which functions for emotion, impulses, and arousal, as well as communicating between the right and left brain hemispheres. A decrease in the volume of the prefrontal cortex, which affects behavior, balancing emotions, and perception. And generally, cortisol levels that are too high can cause inflammation and also interfere with the immune system. And there's also challenges that come with cortisol levels that could be too low as well. So by the time we reach our mid to late 20s, our central nervous system is regulating very complex goal-oriented behavior and abstract analytical thinking. And trauma exposure can lead us to become more primed to perceive threat, potentially have more false alarms, responding quickly without processing all elements of the current situation. So a lot of this has to do with our executive function. We can see the impact on perceptions, how we react to loud noises, other things in the environment that others might be able to just filter out. Persistent hyperarousal, being on the lookout for danger constantly, startled easily, ongoing irritability, trouble sleeping, problems concentrating. We can see the impact of trauma on the brain through our appraisals. We may have what seems like exaggerated responses to people without these, to people who don't have those same altered aspects of the neurodevelopment. So exaggerated response compared to people without those changes. We can see it through emotional reactivity. We may react very quickly and intensely with negative emotions, and it may be more difficult to regain a neutral level. On the other hand, it can also look like avoidance or numbing, where we avoid triggers associated with fear or may feel detached and show a limited range of emotion. Also through behavioral reactivity, we may be likely to engage in dangerous behavior or potentially find it difficult to engage in something perceived as dangerous. And through decision making, some of the behaviors that are objectively unhealthy, like smoking, may have been chosen as coping strategies to deal with anxiety. We see these as both cognitive and relational impacts. Cognitively, that means that we may see challenges making meaning from language, attention problems, ADHD, poor verbal memory or recall, difficulty with rational analysis while in an emotional state, and that a small amount of stress may be perceived as a crisis. And then those impacts can also be seen relationally. Aggression and violent outbursts, poor self-control of emotions, difficulty modifying behavior in response to social cues, or difficulty perceiving social cues, social isolation, difficulty navigating relationships with people, promiscuity. I don't know if any of you can think of anyone in your life or any clients or customers that you work with that demonstrate any of these characteristics that I just described. But what I'm talking about specifically are trauma's impact on the brain. And so you see it in daily life with people behaving with these kinds of interactions. I've been talking about the effects of toxic stress on individuals and their bodies, and I'm going to switch gears now and talk about the effects of toxic stress at the level of population health. Dr. Rob Anda and Dr. Vincent Folletti are the co-principal investigators of the Adverse Childhood Experience Study. That study began in the 1990s, and they call it the ACE study. Prior to this study, most research on health and social effects of childhood abuse focused on a single type of adversity, such as sexual abuse. The ACE study broadened the picture to include multiple types of childhood stressors. These included emotional, physical, or sexual abuse, emotional and physical neglect. These also included household dynamics like substance abuse in the home, mental illness, domestic violence, parental separation or divorce, and an incarcerated parent. And we can think of these dynamics in the household as contributing to chaotic, potentially stressful environments, and maybe experiences that disrupted attachment relationships with the parent. So in addition, the ACE study measured a wide array of health and social problems, from smoking and alcohol abuse to promiscuity and heart disease. And this is really how the ACE study expanded the knowledge into a broader public health perspective. That original study had more than 17,000 participants ages 19 to 94. They all had good health insurance with Kaiser Permanente. They were mostly white and middle class, and they were a sample living in San Diego. And what they found in this group of people is that ACEs were common. 27% had experienced an adult in their home with substance abuse issues when they were a child under the age of 18. 28% had experienced physical abuse under the age of 18. The ACE study found that ACEs also tend to cluster. Where there's one ACE, there are likely others. So it really didn't make sense to study one category of adversity at a time. It made more sense to study the accumulation of ACEs. So the scientists made a score. Each category of ACE, adverse childhood experience, added to the total ACE score. So you could go from having 0 ACE categories up to 10. Their study had 10. So ACE scores in the original study range from 0 to 10. 67% of the study population experienced at least one ACE. ACEs are quite common. And 16% had higher scores of 4 or more ACEs. And these distributions in the general population have actually been replicated in many studies, but in certain groups of people, the prevalence is quite a bit higher. If you survey any homeless population, any prison population, survivors of domestic violence, you will find larger proportions of people with high ACE scores. You can think of the ACE score as a measure of the childhood biologic stress dose. As the ACE score goes up, on average, the exposure to the developmental effects of toxic stress increases. And people who report higher ACE scores are more likely to have health and social problems. In fact, as the ACE score goes up, the percentage of people with health and social problems also goes up. We call this a dose-response relationship. You know dose response from something as simple as filling your gas tank. The more gas you put in your car, the more miles you're going to be able to drive. In this case, where there is a higher dose of adverse childhood experiences, the higher the percent of people with health problems. The dose-response relationship reflects the cumulative stress and developmental adaptations that accompany a high ACE score. This graphic illustrates the many different areas of our lives in which early adversity can have lasting impacts. Injury through traumatic brain injury, fractures and burns, mental health. You see higher rates of depression, anxiety, suicide, and PTSD among adults. Maternal health, higher rates of unintended pregnancy, pregnancy complications, and fetal death. Infectious disease, you see higher rates of STDs. Chronic disease, higher rates of diseases like cancer and diabetes, and often autoimmune diseases. Risky behaviors, you do see more alcohol and drug abuse, more unsafe sex, and access to opportunities. You see differences in education levels, occupation, steadiness, and income levels as well. So ACEs increase the risk for mental, physical, and productivity problems. So in the original study here, which I said has been replicated in many other populations, the same dose response is found regardless of which of the particular outcomes you're looking at for the many, many outcomes that are associated. So for those with the highest ACE score, a much larger percent of them experience anxiety than people with low ACEs or a 0 ACE score. Same with being likely to be smoking or have a drug problem, or 1 in 4 are in mental health treatment compared to only 7% who had 0 ACEs. You see some relationship to work injury and illness, more to missing at least 15 of the last month of work, high association with unemployment, you see it with homelessness, etc. So because of the powerful impact of ACEs on many health and social problems, ACE researchers have concluded that ACEs are a leading cause of health and social problems in our nation. This discovery provides a powerful opportunity for shifting the trajectory of health and well-being for generations to come. So no matter if you're working to prevent heart disease or cancer and homelessness or hopelessness or improve business profitability, as we align a portion of our work around a common goal of preventing the accumulation of ACEs and also moderating their effects, which is what we're talking about. Both of those are promoted by trauma-informed care. We will reduce all of these problems and potentially others all at once. I want to speak briefly about epigenetics. It's a relatively new scientific field, and it explains the ability of our cells to read the messages on our genes and how that ability is influenced by our experiences. Epigenetics involves the attachment of chemicals on our strands of DNA, and then they provide the instructions on how that gene is going to be read. So something that maybe wouldn't have been read based on experience becomes read. It can be vice versa as well. So here's where this is relevant to ACEs. Research suggests that stressful experiences can influence these chemical attachments that influence the reading of our genetic code in ways that can have negative effects on the way our cells function. And this is why it's an important piece to think about when we're talking about ACEs and how it's related to so many health and social problems. And scientists have discovered that responses to stress can be passed from one generation to the next. So they've done some studies of epigenetics with rats. In one study, scientists conditioned the rats to be afraid of the smell of cherry blossoms. Of course, when we say the word conditioned, we mean generally that unpleasant things happen to the rats when they smelled cherry blossoms. And then when the cherry blossom odor came into the rats' environment, they huddled together and they were stunned with fear until that odor was removed. So then those rats had pups, and those pups grew up without any exposure to cherry blossoms. That generation of rats was separated from their parents and placed into a completely different environment. When the smell of cherry blossoms was put into the environment of those pups were jumpy. They had heightened sensitivity to the smell of cherry blossoms. And if we think, why might it be a good thing for rats to feel fear, even though no one instructed them to be afraid of cherry blossoms? It may be adaptive for fear to be passed from one generation to the next if it can prevent poisoning or avoid dangers. So the field of epigenetics can help us understand how groups of people may be deeply affected by historical trauma. And the hopeful part of this is that other types of positive life experiences may also affect the reading of our genes and have positive effects on human development and well-being. So I want you to stop for a moment to wonder, why would a 12-year-old be more likely to smoke if they have higher ACE scores? What does it feel like to be a 12-year-old with a high ACE score? The effects of ACEs on the developing brain leads to a higher likelihood of feeling depressed, anxious, or having difficulty concentrating. It turns out that nicotine, which is efficiently delivered through inhaling cigarette smoke and through vaping, can reduce anxiety, feelings of depression, and improve concentration. So it's not necessarily any wonder that kids with high ACE scores are more likely to smoke. For them, it may simply be a form of self-medication with a non-prescription drug. And similarly, injecting IV drugs can be a way to cope with the feelings and circumstances that are a consequence of higher and higher ACE exposure. So this concept of adaptive behaviors, even those with known negative consequences, in the face of the effects of ACEs, leads us to the idea of trauma-informed care. This idea changes the question from what's wrong with you to what happened to you. And this way of asking people about problems related to ACEs reduces blame and shame, and it leads to a more compassionate, kind types of interactions. So I do want to reinforce what the original investigator, Dr. Rob Anda, feels is important, is that the ACE score as it was originally designed is not a diagnostic tool or a screening tool. It's not a predictor at an individual level. It's also not a fun quiz. The ACE score is a history tool. It's a communication tool to comfortably talk about life experiences. It's helping become part of common language for us to talk about these issues together. And it can be a gateway to empathy, compassion, and healing. So there is some controversy about the move to do screening based on ACE scores. And it's important to know that in those contexts, an ACE score is not just a single piece of information that, those questions about the experiences that have happened, in many cases asking children what they may have already experienced at whatever age they are, that is part of an overall comprehensive system of care. But on its own, one should never think of an ACE score as one's destiny. And that's very important. I do want to mention the lack of racism in the original study in any form. So the list of ACEs in the original study is not a list of every possible or every meaningful source of traumatic stress. And there is a growing body of research about how racism is a source of ongoing stress in the body, and that children begin internalizing that stress at a very young age. Also want to talk about different types of trauma. So many Indigenous peoples and different people of color in our nation have experienced cultural trauma, which is an attack on the fabric of their society, affecting the essence of community and its members. The historical trauma being a cumulative exposure of traumatic events that affect an individual and continues to affect subsequent generations. And that's more on the collective level. And you do also have that intergenerational trauma, which occurs when trauma is not resolved, subsequently internalized, and can get passed from one generation to the next. And I'll show you in a few slides ways in which that happens. Historical trauma, again, is a definition that has been offered as collective emotional wounding across generations that results from massive cataclysmic events. And this trauma is held personally and transmitted over generations. And there are numerous examples of historical trauma that are impacting families and communities that we work with every day. This is true for Native Americans in our region, and it's also true for many other groups. This is a picture of children at the Carlisle Indian Industrial School in Pennsylvania, circa 1900. This is part of the boarding school era when children were forcibly removed from their parents and beaten for trying to speak their language or practice any of their customs. And it's a very dark part of the policy that the American government had toward Native Americans. One challenge that we have when we talk about historical trauma is the word historical, because when we hear that word, we might think it's something that's just in the past, but really it is still affecting the present. It's in the ways that people relate to one another and in the bodies and daily thoughts of people affected by historical trauma, and we see it in the challenges that communities face today. This image shows the effects of structural racism on social determinants of health. So in the star, each of the star points, we see different social determinants of health, things that regardless of individual decisions and choices are bigger and more societal and contribute to the health and well-being that people experience. So that includes the neighborhood and built environment, health and healthcare, education, social and community context, and economic factors. So structural racism, there's a lot of examples given here, but it underlies many poor living conditions, prevalence of food deserts, decreased quality of care, disparities in access to quality education, experiences of discrimination, disparities in rates of incarceration, experiences of housing instability, and poor employment opportunities. So it's just important to acknowledge social determinants of health in general and the importance that they have on health and well-being, and also look at ways in which structural racism is affecting those. So one of the challenges that people have had with the original ACE study is that it really is only focusing on what is happening inside the home. So original conceptualizations that have become common that are trying to expand to include more adverse community environments. I like the image on the left with the tree and the roots, where the roots are, the soil and the roots are what we grow from, and that many of the dynamics described in the soil represent those social determinants of health, and that researchers are moving now to a more expanded version as well, recognizing the impact of the environment. So you have the household, you have this more community level influence with the roots in the soil, and then you also have really severe impacts that are beyond individual control, and a lot of environmental impacts affect vulnerable communities harder than others. And those are natural disasters, which have been happening, but also furthered by the climate crisis brought about by climate change. Many risk factors are more common among people with high ACE scores. So I'm going to talk a little bit about that intergenerational component. In this analysis of risk factors for poor birth outcomes, several of the risk factors are experiences that are more common among people with high ACE scores. So this includes smoking, higher rates of smoking among people with high ACE scores, higher rates of unplanned births, higher rates of illegal drug use and alcohol use, presence of sexually transmitted infections. And these things during pregnancy are associated with poor birth outcomes, including preterm and low weight births, but also infant mortality. When we look at this data here, as we do here by race, we see that there are significant disparities between mothers who are white and mothers who are American Indian in terms of the risk factors that they're experiencing. And I want to talk about that briefly when I talk about this data, which is from the National Survey of Children's Health. And the data that I'm showing on this slide is from an analysis I did with epidemiologist here in North Dakota, Devaya Mukatira, and also a colleague, Dr. Kenny, out of Health Resources Services Administration. She did another analysis where, again, she found significant differences in her analysis on a national level for whites and American Indian children, but she adjusted for sociodemographic factors and found that a great deal of the elevated risk among American Indian Alaska Native children could be accounted for by child, family, neighborhood, and residency factors. So essentially, when you are able to control for factors related to social determinants of health, you no longer find that the difference is really about race. It's about the inequalities. But again, the experience of racism and discrimination itself is another form of stress, and that toxic stress also contributes to the effects of high ACEs. So in this graph, ACE scores can reliably predict higher rates of challenges as an adult, which in turn becomes the basis of the ACE score for the next generation. So this survey is one of the first that I know of that attempted to assess ACEs of people who were children. And so it's parent report, self-report. And so they were not asked about whether abuse was happening in the home of the child, but they were asked about things like whether there was experiences of divorce or parental separation, whether there were any alcohol or drug problems in the home, socioeconomic hardship, victim of neighborhood violence. Again, that's getting at more of the roots and the soil. Mentally ill or suicidal person in the home, whether the parent served time in jail, whether the child witnessed domestic violence. And so you can see that really a significant difference by race again, but what you can see is that the challenges and chaos that having a high ACE score causes parents is then translated into the child's own ACE score, because these are all factors that would get counted in the child's ACE score. But we do see this huge gap for white children compared to American Indian children in North Dakota, and they are significantly more likely than whites to have had these experiences. And you see this when you look at children who've experienced 2 or more ACEs as well. So at the age of, so the graph on the right, the graph shows that among American Indian children who are 0 to 9, what are the bar on the left, 28% had a score of 2 or more. And for children 10 to 17, it was 74%. And this data, you see a rise among white children as well. And this data shows why we get very excited about home visiting and programs like that, because this is a very important window of opportunity for working with pregnant women and families with young children and interrupting that intergenerational transmission of ACEs. So when we support the families who already have ACEs, you can't prevent the ACEs that those adults have, but you can work with them in a way that promotes their well-being and promotes their ability to prevent either increasing or causing any ACEs for their own children, which is really powerful. So I want to reinforce the idea that ACEs are not destiny and that people affected by ACEs are becoming the leaders of self-healing communities. My own high ACE score and that of my mother drives my passion for educating and researching about this topic. This is me with my 2 little pumpkins. Let's see, I think it's about a year old, but I've got a 10-year-old, the one on the right, and an 8-year-old, the one on the left, so Connor and Bryce. But I'm also a proud Head Start alumna. So when we talk about that important window of intervention, you know, we experienced that in our family, and it was a really significant benefit, and I believe changed the trajectory of my life completely. So the ACE study provides us with straightforward information about the consequences of toxic stress during childhood. And this research really gives us powerful information that we can use to improve health, safety, and prosperity. But, you know, in and of itself, ACE study does not really provide a roadmap of what we are supposed to do. So we do have a collective choice. We can actively develop skills and accommodations that are going to enable everyone to contribute to their communities. Or we can continue the societal pattern we've had of basically rejecting people for the normal adaptive responses they had to childhood adversity that makes them not, you know, super well adapted to normal life. So before we assume that a person's behaviors are stubborn or annoying or self-destructive choice, let's think about the possibility that adversity may be at the heart of the challenges they're seeing. And this is an important statement. Risk factors are not predictive factors because of protective factors. So when we say that a high ACE score does not automatically lead to all of those things, or why can one person with a high ACE score be doing quite well and another person with a high ACE score is homeless and an IV drug addict? And a lot of that has to do with protective factors. So here we're looking at those risk factors again, all of the various chaotic, severe, prolonged, uncontrollable forms of stress, maltreatment, domestic violence, community violence, cultural marginalization, poverty. But on this side, you see the connectedness and the factors that promote resilience. And that includes cultural connections, safe and stable families, safe and stable communities, secure income and housing, and meaningful work. And one of the most helpful illustrations to talk about risk factors and protective factors is the seesaw or teeter-totter, depending, I guess, on where in the country you learned the word. And so the fulcrum there in the middle is just showing that when positive experiences outweigh negative experience, then the seesaw tips towards the positive outcomes. That fulcrum can be set in part by your genetics and your biology. So if your fulcrum is a little bit more to the left, then it's going to be more difficult and negative experiences would maybe have more weight. But we can also shift the fulcrum to the right and make it easier for the seesaw to tip towards more positive outcomes. And the factors that we can do to promote resilience and trauma-informed approaches can shift that fulcrum more to the right. So you are looking at a balance or trying to overcome an imbalance. So one of the things that we can talk about in terms of positive experiences that can help tip that scale and allow people to thrive even with adversity that they've experienced are these core protective systems. So these three powerful systems interact and help guide positive adaptation. They are individual capabilities, attachment and belonging with caring and competent people, and protective community, faith, and cultural context. And we do know that people do best when the three protective systems are nested. So when people are living in thriving families and communities. And nurturing the healthy development of these protective systems affords an inoculation for overcoming potential threats and adversities. And damage or destruction to these systems also has dire consequences for people who are already struggling. I just want to take a minute to talk about each of those systems. So individual capabilities, when we go out of our way to notice the core gifts of each person and help give them opportunities to give those gifts to a community that they care about, we're helping to generate that positive view. Holding a positive view lets me know I'm important and valuable. It helps me to ask for help when I need it. And it's also about the story that we tell ourselves that says, good things happen to me. It has to do with our self-efficacy and the belief that what I do influences what happens to me. That's an important component of home visiting programs with pregnant women and young families is goal setting, helping families know that they can set and achieve goals and build that self-efficacy. Self-regulation is another part of individual capabilities, which is our ability to gauge our state of mind and emotions and keep those under control while we navigate a social situation. And if we're not reading the situation or adapting our behavior, then we see that the social aspects of life become more difficult. Now, I'm curious if any of the words that I used in here piqued anybody's kind of questioning in their minds, because these are the same individual capabilities that are often the very same capabilities that don't develop well when a child experiences toxic stress. So the individual capabilities that are associated with recovery and resilience are often not developing properly during periods of toxic stress. So believing that people can just try harder to be what their biologic adaptations keeps them from being is a circular logic that is not helpful to those people. But that illustrates why the other systems of support are so important. So the next protective system being attachment and belonging. Relationships with caring and competent people are vital contributors to resilience and recovery. And the competent piece in particular means that the person who is providing this buffering can learn and improve their skills and competencies when relating to people who have been hardwired for survival in a dangerous and unpredictable world. And people who have difficulty with emotional regulation, picking up social cues, problems with addiction, strained family bonds, other consequences of developmental trauma, they can be challenging friends and neighbors. So it's very important that, that other people in their lives are developing those skills and competencies. And the third protective system is about thriving communities. Improving health and safety for current future generations can happen through fostering thriving communities. And this is a lot about empowerment and including the people who have the most at stake so that they can be the expert leaders of their own community's change. And when we invest in community capacity and share the knowledge about ACEs and resilience, we can provide a common language for collaborations as well. Building community capacity is about helping people learn and manage and improve their efforts systematically. Success isn't going to happen overnight, but it is a journey that intentionally builds new capacities that support healing and prevention. And ACEs are so common that we can't succeed in making the changes that we need by using direct service interventions alone. So one of the things that I mentioned about home visiting, parents who are most affected by ACEs are the people with the most power to prevent transmission of ACEs to the next generation. Another thing is that a lot of the people who are in helping professions are themselves people with relatively high ACE scores. And so ACEs are common both in our clients and among our helping professions as well, and really across just about every sector. Parenting can actually feel more difficult for people with ACE attributable problems, again, if they have trouble with self-regulation. So our role as neighbors and friends and extended family and professionals in social health, justice, education, other services is to lend our support and expertise to the population that is affected by ACEs to help them build their own resilience and leave a better legacy for their children. When communities engage in capacity building, they're really also digging deep into human experiences that have shaped their past and influenced the present. And the original ACE study didn't measure trauma like slavery or children being taken from their parents in boarding school. But the neuroscience and epigenetics research suggests that these and other traumatic experiences that create toxic stress have enduring effects today. But for every trauma history, there's also a survival history, a history of resilience. Cultural continuity, including reclaiming cultural ways after a time of loss, is a very powerful driver of well-being. One of the first things that has to be done is to ask the community what is important to the community, because they know the answers to their own problems. In a study about the effects of cultural continuity in Canada's First Nations, two researchers, Michael Chandler and Christopher Lalonde, found that self-government, land claims, education, health services, cultural facilities, and having tribally controlled police and fire significantly reduced the relative risk of suicide among youth. The right to self-govern reduced relative risk of youth suicide by 85%, while cultural continuity and education reduced relative risk by 52%. I want to talk more about the help that helps and the role that we can play. And when we are intentional about helping, and we do it in a thoughtful way, and I'll be talking more about the principles of trauma-informed approaches in a few slides, there are resilience factors that we can contribute to that make a difference. And they are even more powerful when we layer up. So feeling social and emotional support and hope, having two or more people who help, two or more people who can give concrete help when needed, community reciprocity and watching out for children, intervening when they're in trouble, doing favors for one another, and social bridging, that people can reach outside of their own social circle to get help for their friends and family. Now, I'd like to have an interactive component here. So I'm going to ask everybody to go to menti.com. It's a website. where I'm going to be able to have you do an interactive poll. Okay, I'm waiting for the code to be generated. Okay, so the code, and I'll put it in the chat as well, is 5218839. Some of you have found this already. I've probably had some experience with Menti. So how often do you get the social and emotional support that you need? Always, usually, sometimes, rarely, never. Again, at menti.com, menti.com. If you enter that 7-digit code, which I put in the chat, 5218839, then you'll be able to answer this question. And I believe you can see the real-time results on my screen right now. Okay. Give it another few seconds. And go ahead and keep menti.com open because we're going to have some more questions today where we use Menti. So I didn't ask to give it in percentages, but we can see that a portion of people feel that they always get the social and emotional support they need, which is terrific. A really large portion say that usually that's true. And then you have a fairly large portion that say sometimes, rarely, and never. I have to say that when our children were younger and I had opportunities to be looking for employment out of state, one of the factors that mattered to me was putting myself in a situation where I did not have social and emotional support that I needed, or the concrete support that I needed, which we'll talk about shortly. So get out of that and get back to the presentation for a second. So in this graph, we're looking at data from the Behavioral Risk Factor Surveillance System for Washington State. The bars represent the percent of people who had poor mental health for more than half of the last month. So it's the percent of the population with poor mental health for at least half of the last month. And the two different colors of bars represent people who have low support and hope in their lives and those who have high support and hope. If you look at the darker bars, this represents people who say they have low levels of support and hope in their life. And you see that dose response that we've come to associate with ACE scores. So lower percent of mental health challenges among those with 0 ACEs, and a much higher percent among those with higher ACE score who had those mental health challenges. But now look at the turquoise bars. These are people with high support and hope. The percent with mental health challenges across every category of ACE is much lower. And it's a really powerful example of how critically important having support and hope is, and the role that other people can play in that, and how powerful of a protective factor it is for people with high ACEs. So that is just an incredibly dramatic drop from nearly 40% to under 10% when people are able to have that social and emotional help. Now remember, people can be difficult. It can be hard. And so people need to make the rest of us, everybody else need to make, informed, intentional skill building opportunities and exercise those opportunities to provide support. So back to menti.com, please. And now I want you to think, how many people can you think of that could give you concrete help if you were in need? Somebody who could pick up your child, money for your heating bill, your car breaks down. So 0, you can't think of anyone. 1, 2, 3, and the 4 or more. I'm definitely seeing a pattern. For the most part, many of us feel that there are lots of different people that they could reach out to give concrete support help if they were in need. And this is the one that I was thinking of as well. I think one of the first times that I was in the situation to be determining, if I wanted to be applying for jobs out of town after I finished my PhD, and Corey and I had just had the stomach flu and my sister, well, we had the stomach flu. My sister was able to come over and I had the bathroom upstairs and Corey had the bathroom downstairs and she had the baby. And that's the kind of concrete support that people need. And so it can be really difficult if you're isolated and don't have that. So thank you. Looking back at the data, this is looking at hunger and whether or not you have concrete help. So in this graph, the bars represent the percent of people who said that it was often or sometimes true that the food that they bought just didn't last and they didn't have money to get more in the past year. And the two different colors of bars again represent people who have low concrete help in their lives and those who have high concrete help. And if you look at those darker bars, again, you see that dose response, that people who say they have low levels of help in their life, you know, fewer of the people with 0 ACEs say that, and more of the people with higher ACE scores say that. But again, if you look at the turquoise bars, that these are people with high concrete help in their lives. So again, the percent experiencing hunger across every category of ACEs is much lower. And again, how critically important other people who are able to provide concrete help is for the well-being of people with high ACEs. So trauma-informed care principles, the concept of trauma-informed care first began in clinical settings, how you can provide trauma-informed care in a clinical setting. But people have realized that trauma-informed approaches are incredibly relevant and important to non-clinical settings also. The Substance Abuse and Mental Health Services Administration, SAMHSA, has provided some really seminal important guidance for trauma-informed approaches that apply to a wide array of settings and relationships. So the way they define it is that a trauma-informed approach is built on 6 principles. So you have safety. So for an example, throughout an organization, patients and staff feel physically safe, but also psychologically safe. Trustworthiness and transparency, so that decisions are made with transparency and with the goal of building and maintaining trust. Peer support, that individuals with shared experiences are integrated into the organization and they're viewed as integral to service delivery. Collaboration, where power differences between staff and clients and among staff are leveled to support shared decision-making. Empowerment, where patient and staff strengths are recognized, built on, and validated. And this includes a belief in resilience and the ability to heal from trauma. And also humility and responsiveness, that biases and stereotypes and historical trauma are acknowledged and also addressed. Utilizing this framework, we can help communities become aware of traumas that have affected them and how disparities within their communities are tied to these experiences of trauma. And a lot of times that self-revelation is really empowering. There's also the 4 R's of trauma-informed approaches. So the first is to realize the widespread impact of trauma and understand potential pathways to recovery. So when we talk about trauma-informed approaches, part of it is educating yourself about trauma and understanding the potential pathways to recovery. It's about recognizing the signs and symptoms of trauma among people in our lives. What is it that we are experiencing that previously would have just been irritating, but now we recognize are probably symptoms of trauma? We can respond by integrating knowledge about trauma into policies and practices, and we can actively resist re-traumatization or triggering trauma reactions in people. So an example of re-traumatization, what are we talking about that? So you can see examples both in systems and within relationships. So at the system level, it would be things like having to continually retell their story, being treated as a number, procedures that require disrobing. Is that absolutely necessary? Being seen as their label, they are an addict instead of a person experiencing addiction. They're not given choice in service or treatment, that there's no opportunity to give feedback about their experience with their service delivery. So oftentimes these are just labeled as, well, that's our policy or procedure, that's just the way things are done. I remember talking to someone earlier this winter, and he was advocating for an immigrant in the community. And one of the challenges is she had no control over the heat in her unit, and she was freezing. She had COVID-19, had a fever, and had no ability to adapt her own living environment to respond. And so that would definitely not be a trauma-informed approach. In relationships, not being seen or heard, violations of trust, not making efforts to ensure emotional safety, not being collaborative, doing things for someone rather than with them, and using punitive treatments or coercive practices, oppressive language. Those are all ways that re-traumatization can occur. Another example, potential trauma-related triggers can happen in healthcare settings, and it can be really confusing as healthcare providers or providers of social services and other helping agencies that we're here to help, and we work really hard at helping. So how can a helping environment trigger arousal in or even re-traumatize children and families we work with? But you have to really understand that it's the entire environment. It can be the sites, it can be feelings of invalidation, it can be the procedures themselves, it can be sounds, it can be communication barriers, it can be that feeling of lack of power. So even if an individual helper is being very compassionate, the environment itself can be very triggering. So when would we think of trauma? And the answer is always, but especially when someone is acting irritable, if they're avoiding appointments or procedures. And you can think about this not just if you're the care provider, but there's someone, a loved one in your life who's avoiding appointments. What is going on there? If they're ambivalent about their own health, symptoms of depression, history of substance abuse, chronic problems with pain. And you can be respectfully curious is one way. You know, I've noticed that you're having a difficult time getting to your appointments on time, and I'm wondering what's going on with that. So one of the things about having these conversations and talking about adverse childhood experiences and ACE score is that it can also normalize the conversation and normalize having conversations about difficult topics that oftentimes people maybe have never even been asked about. I know there are concerns sometimes that people are going to be triggered just by talking about their ACE score, but you know, these are things that people live with all the time, and the ACE score on the whole has been found to be a really empowering piece of information that can also trigger a lot of I guess self-reflection and self-compassion. There's an exercise that I like to do when sessions are longer, and it has to do with looking at our own executive functions. And I remember it was a really big aha moment for me when we kind of self-rated which areas of our executive function we were strong at and which we were struggling with, and to realize that areas that I struggled with that I'd actually probably had shame around, like, you know, I'm clumsy, or I have a terrible sense of direction, or I have a really hard time with short-term memory, really has to do with developmental changes to the brain, you know, as adverse experiences occurred. And that can give you a sense of better understanding of what you're dealing with, and then also recognition that there are things you can do about it. So when we talk about excessive stress, that it affects how well we develop and use our executive function skills. So in childhood, severe frequent stress can redirect children's brain development away from planning and impulse control towards building capacity for rapid threat response. So it's changing what the priorities are in that developing brain. Those stressful stimuli are primarily automatic responses. That is not the more advanced part of our brain that is necessary for executive function. In adulthood, excess stress overloads adults' ability to use executive function. So not only is there potentially a change in how the development occurred, but even as adults, excessive stress is impacting our ability to exercise our executive functioning skills and intentional self-regulation. And it can put us more on an automatic response. So core capabilities are things like planning, focus, self-control, awareness, flexibility. So if you have a particular difficult time with things like that, you're going to have a very difficult time with, the skills potentially to be really successful in a work environment. And that's where you can see some of those impacts. So ACEs really help us understand ourselves and our coworkers better, the children we work with, the parents we work with. And it's important to recognize that there are strategies for working with people who have executive skill challenges. This is just a quick example. And I want to make sure that we have time for questions. I'm going to make sure we get through the rest of my slides fairly quickly. Science tells us it's never too late to help adults build up core capabilities. So there's things you can do, modeling self skills, attuning with empathy to the stressed person, making plans and developing strategies ahead of time for difficult or stressful situations. There are other examples of ways in which trauma-informed perspectives can be helpful. This is a study that I'm working on right now with Dr. Susan Ray-Daggs. We did a scoping review of the literature, which confirmed our conceptual model that there really isn't a lot of direct research about this, but that we really do need trauma-informed approaches to helping aging adults age in place, especially aging adults with adverse childhood experiences that are often compounded by those adverse adult experiences, and that there are specifically community supports that can be put in place that can help ensure a better quality of aging experience and higher quality of life with aging. North Dakota has a really tremendous trauma-sensitive schools initiative, which many of you on the call are probably familiar with. There's a curriculum that you go through. There's the modules. Like we said, part of it is the education. Then you learn strategies, and you also learn how to not experience secondary trauma yourself, and in certain cases that people have their own traumas already to deal with. So a trauma-sensitive school is a safe and respectful environment that enables students to build caring relationships, self-regulate, and succeed academically. This is an example of a strategy that was implemented by a principal of Lincoln High School. It's an alternative high school in Walla Walla, Washington, and it was featured in a really excellent documentary called Paper Tigers. So after he learned that most people are not biologically wired to be rational, that at the same time they're emotionally triggered, he came up with a new discipline process. And it's this simple graphic of a target. And in their school, teachers and students identify their emotional state before any disciplinary conversation can begin. And if either person, the teacher or the student, is in the red, then they wait hours and maybe even a day before they begin to talk about what went wrong and what should be done about it. At that point, the individuals involved can be calm enough that they can actually be active partners in the conversation and about what to do to take care of themselves and others. And just using this strategy and some other strategies around, trauma-informed approaches, he was able to reduce suspensions by 85% in his school. And that led to better graduation rates. And that also means students are less likely to enter the criminal justice system. There are things like the trauma-sensitive school checklist. This is one from Learning for Justice, and it talks about how ready are you or where are you at with respect to being a trauma-sensitive school. And you can look at school-wide policies and practices, classroom strategies and techniques, collaborations and linkages with mental health, how you do your family partnerships, and also how you're linking people to the community. And I am more than what happened to me. I'm not just my trauma. So one of our challenges is that we're still trying to find the right way to talk about it, and the language keeps evolving. So a healing-centered approach is what some people are promoting now instead of a trauma-informed approach. So a healing-centered approach addresses trauma through a different question, moving beyond what happened to you to what's right with you. And it views that those who are exposed to trauma are agents in the creation of their own well-being rather than victims of traumatic events. Well, a lot of those principles are there in trauma-informed approaches. And so it's not that the core aspects aren't there, but the language can potentially be a problem because, trauma-informed makes it sound like we're just focusing on the negative. So it's just a perspective to keep in mind that it's an evolving field of science, and and language may change around it, and there's important shifts, that happen, but those core principles about trust and safety and collaboration, those are going to remain. So I'd like us to go to Menti again, and these are some of those reflection question briefly. What are 2 to 3 things from what I talked about that you would see yourself sharing with others? And you should be able to enter a couple of different responses if you want, short phrases. So again, menti.com, using the code 5218839. What are a couple of things that you can see yourself sharing? Talking to my siblings about ACEs and how to mitigate passing on trauma. That ACEs are a guide, not a diagnostic. Being respectfully curious. When to have difficult conversations. How historical trauma affects people. Epigenetics, trauma-sensitive schools. Utilizing a healing-centered approach. The way the mind develops differently when exposed to traumas. Those graphs showing the impact of having support. That you are more than your trauma. That ACEs don't determine your fate. A healing approach versus a trauma approach. Historical trauma is not just historical, also current. So some, really powerful takeaways. And there's a lot that we need to dig in. There's, we can only scratch the surface with an hour, but I really appreciate those of you taking the time to reflect on that. I'll give you another few seconds to brain trauma versus no trauma, assets rather than traumas. I don't know if I can be the one to scroll it or not. Trying something different. All right, thank you. So, yes or no? Research has demonstrated that larger doses of childhood adversity are associated with poorer outcomes in adulthood. And you may recognize these as some of our CEU type questions. Yes. Research has demonstrated larger doses of childhood adversity are associated with poorer outcomes in adulthood. Your ACE score is your destiny, true or false? Okay. Definitely understanding that our ACE score is not our destiny. And key principles of trauma-informed approaches include safety, trustworthiness, transparency, collaboration, and empowerment, true or false? Okay, consensus again, wonderful. Okay. I wanted to share with you briefly, and we can put it in the chat box. The CEU credit that's available has been approved for general social worker, North Dakota only, and counselor for 0.15 CEU. I had to ask, it's different than contact hours. So the link to register for CEUs, the cost is $10. I made a bit.ly, but the full link is here as well. So I will pop that in. You just go in and enter the necessary information about this session and pay your $10, and they'll get you the information you need. And then I also wanted to let you know that a recording of this presentation will be available on YouTube at this link. If you lose track of the link for some reason or having trouble finding it, You would go to YouTube and search NDSU College of Health Professions and look for the title of this seminar, and they will have a public health playlist. It's going to take a couple of days to get that posted. You'll be able to view this link and come back and pause the screen on anything that you want to look at. But I did include some resources that I think might be of interest for those of you who don't know your ACE score and are interested. You can go to ACEs Too High. There's some trauma-informed care resources for, I think it's the National Childhood Trauma Stress Network. I feel bad that I can't say that. There's the Trauma-Informed Care Implementation Resource Center. ACEs Connection is an excellent, excellent resource where the newest information about ACEs and resilience is shared in a collaborative community. More about trauma-sensitive schools here in North Dakota. The Center on the Developing Child at Harvard has been at the forefront a lot of the neuroscience. Institute on Trauma and Trauma-Informed Care, and kind of a neat website called kidsmates.org. And lastly, I just want to thank Prevent Child Abuse North Dakota for their continued support of the ACE interface license in North Dakota, and open myself up to questions and discussion. And that's my email address for anybody who'd like to follow up with me directly. Thank you.
All right. Well, this is Mark Strand here. I'll be taking care of the Q&A session. I think we should use our reactions button to give Dr. Danielson a nice round of applause. Thank you for your presentation. And we could just have people ask questions, I guess, but I'm afraid it's going to be people bumping into each other. So please enter your question into the chat. And so far, I haven't seen any entered. So we'll just wait for a minute until we see the questions appear. Maybe I'll start it off. One of the things that's difficult is to imagine dealing with things, we want to be able to prevent these problems. So looking forward, the prospect of a better world in which people can grow in a less traumatic world in which to be raised. But we have so many people who have already spent 10, 15, 20, 30 or more years experiencing these experiences. So how do you give us encouragement when we think about the degree of damage that these experiences have already done? And how do we apply these principles to care for societies and populations that have been victims of these things?
I really appreciate that question, Dr. Strand. The emphasis for so many, and as a person who works in maternal and child health, justifiably so, our focus is on prevention. We want to prevent, but sometimes it also feels like, well, if you can't prevent them all, then you failed. And if you think about the graph, the difference between the prevalence for 0 to 9-year-olds and 10 to 17-year-olds is if you can keep that score down, there is less cumulative impact, that burden is less. And then furthermore, the trauma-informed approaches that we can implement, I use them and they're relevant to me in every sphere of my life. And a lot of times what they say, and for several people on this seminar, they probably have heard this information before, but a lot of times you get something new when you hear it, maybe not all of the information, but definitely the ACEs part. And you go from sort of applying to yourself to family members and coworkers and then clients, and you kind of keep expanding your reach. So the more that people become educated about it, it's sort of like you can't go back. Once you know it, you want to act on it. It changes how you think about problems and solutions facing our communities. And you really can. I mean, when you think about the graphs about what a tremendous difference having supportive people who foster that sense of hope, having concrete help when you need it, people with high ACEs, way, way, way lower, like, much closer to the experiences of people with no ACEs. And so, and so I guess that gives me a lot of hope. But I also personally, in my research, am looking specifically at mitigating the impacts of trauma as people age, because aging is already a challenging experience. So that's where I mentioned that research around trauma-informed aging in place, and that we have the opportunity to consciously, intentionally create environments that are improve quality of life.
Mm-hmm. Good. Any questions? I guess feel free to just turn on open your microphone and just ask your question.
I have a question. This is Marlinda. Thank you, Dr. Danielson, for your presentation. Appreciate it.
Hi, Marlinda.
My question is, maybe you had mentioned this in the beginning of your presentation, but just in terms of the ACE assessment, do you have to be trained or be certified in providing that to audiences you serve?
No, you do. So interesting question. You do not have to be trained to share the ACE questionnaire with others. But if you are looking at incorporating knowledge about ACEs or asking and having conversations about ACEs into a work environment, then I would encourage you to look at some of the trauma-informed checklists and think about some of the ways that that there can be sort of a wraparound effect that you can, when you draw attention to that you've thought about how you're going to have that conversation, what resources you might want to connect people to, ways that you can sort of back up the importance of that information with the practice that you're doing in your place of work, so that you're walking the talk to that extent as well. So, I mean, within our individual spheres of influence, and that happens on so many levels, individually, yeah, I mean, I've shared the questionnaire with people, and it can lead to really great conversations. But organizationally, I would encourage, a broader conversation, and the opinions of leadership really matters as well.
A question did appear. Is there a more expanded ACE questionnaire? I'm assuming that the 10 question is the only one, correct?
No, there ends up being different questionnaires, and has so for example, there's a really great data set midlife in the United States that I use for my dissertation, and they have a lot of really interesting questions about outcomes. And then you could get at things that were adverse childhood experiences, but it wasn't the official 10. So I actually created my own index and validated that index. And it included some other things like moving frequently. That was supported in the literature. Kind of a different definition of sexual abuse based on the questions that were available. Deprivation, and those types of things that the literature does support. So what happens, I've asked about this. I've actually asked Dr. Anda and Laura Porter, who's done some amazing work in Washington State. And I was going to say, looking to the examples of others who've been doing this work for a while can be really inspiring. There's a lot of really great work that's been happening across the country, and it continues to build. But Dr. Anda specifically, oh shoot, I think I may have lost my train of thought. Wanted to get that in there. Can you help me, Dr. Strand?
Where the question was at? It was the length of the ACE questionnaire, whether there was an expanded one or whether it was just the 10 items. I'm sorry. Yeah.
Dr. Anda recommends that people stick to those same 10, because then we can sort of compare apples to apples when we're dealing with different populations. Because if you have an ACE score of 20, well, what does an ACE score of 14 mean? Generally, what they find with that dose response relationship is that you're looking for that accumulation. So if you have experiences that have some prevalence, things that are, if you had 10 items that almost nobody experiences, it's not going to be a real good measure. but things that have some prevalence, you know, as soon as you start getting some co-occurrence, which tends to be what happens, you start finding that dose response relationship. So it ends up being less about which specific adversities they are. So, I mean, if you want a survey of like, what are the various adversities that people experienced, you know, that's important information, but it's not necessary to be able to detect that dose response cumulative stress load. But I would say that they've created a version for the World Health Organization that includes some different elements, including things that are more like child soldier, experiencing, you know, extreme, you know, warfare in your home country, things like that. So there have been some adaptations, but generally there are a lot of different studies, and some of them do choose to use other items, and that's just fine. It just makes them a little bit harder to compare. The behavioral risk factor surveillance system is the best system of ongoing surveillance, and they are using the original 10 questions, except they did not, they found it too difficult to validate questions about neglect. So their score is a score of 8 instead of 10.
The next question has to do with the fact that trauma in individuals manifests itself in school, in social work settings, in clinical settings. How can we create a more holistic approach that takes into consideration the multiple players that are involved with individuals in the trauma they've experienced? And in which areas could use the most work or need the most help in that?
Well, hi, Claire. Thank you for your question. And hi to Divya earlier. You know, a lot of people are using language that is really trauma informed, even if they don't know about it. And then it's that siloing effect. So when you hear people talk about wraparound services, I see that as one of the best solutions, you know, that the different systems are talking to each other. But in general, I think if people, you know, you start seeing the applicability of these principles in lots of different areas. So I see them in housing, I see them in nutrition, I see them in addressing addressing obesity through physical activity and nutrition. And so to bridge the gaps, I think the more that everybody is educated about this, it just becomes part of the common language. So I was actually talking to my mom before this, and I said, you know, I'm dedicating the first part of the seminar to some information that some might have heard, but I can't assume everyone's already heard it. And so, you know, the more we get to the point where you can feel confident that everybody is familiar with the concepts, then you can sort of move right into the meat of it and have those conversations. But in terms of what could use the most work, I mean, you know, when I'm thinking of children, the informed practices in schools is just so tremendously important. I think by definition, you know, maybe I'm just, you know, just met so many wonderful colleagues, but I think the social work and the clinical settings, you know, by nature are very open to trauma-informed approaches. I think what's most different for people is maybe to think about how they can operate like as an organization in a trauma-informed way. If you think about people's interaction with the healthcare system, it starts from the moment they walk in the door in terms of how the environment is, you know, you might just think of it, oh, it feels airy, but maybe that's what makes it feel safe, as opposed to if it's really dark and the lighting's not very good, and that's a triggering event for somebody. So even just the way that, you know, the environment is set up, but then the way that the person greets them, I do think that the experiences of social services can be unfortunately very triggering for people. It can feel very dehumanizing. It can feel very, you know, asking very probing and private questions. And so there are definitely ways that people can be conscious of how to do that. And there's examples, some really, really interesting examples of how people have reworked how they're doing probation and, you know, WIC clinics and all of these different things. So in terms of what area, I would say every area. If you're in that area, that area needs it, is basically my response. The Laura Porter is really great about just talking about working within your sphere of influence and trying to reach out to, you know, to people who then are in a new sphere of influence, and they can make changes within a setting that maybe you didn't have much impact on before. I would say that I was able to do a pre-service with Janelle Regenball, who is another ACE interface master trainer. And that was in August, and it was before Sendka here in Fargo, before they had their new Head Start year, I guess. And the pre-service that she asked us to do was about 4 hours, and she invited everyone. She wanted the lunch personnel, you know, the administrative people. She wanted everybody to have that basic understanding of trauma. And then some people, I think, need to dig deeper, but it does need to be at that leadership level, just like it needs to be in terms of addressing diversity and inclusion. And there's overlap with so many of these concepts in terms of both what outcomes there are and what possible solutions can be, that you know, that really needs to be leadership on board as well. So there's something to say for grassroots, but for something really to take hold, you have to have that backing by leadership. I was kind of a non-answer, Claire, but answer was everything.
All right, well, I don't see any more questions, so I think we'll start to wrap up here. I did want to point out that next Monday, we'll be having another seminar series, 2 back-to-back here, just because of the way the scheduling worked. But next week, Dr. Rick Jansen will be giving a presentation entitled Multi-Omics Analysis of Public Health Data on Pancreatic Cancer. The same Zoom link as for today, as the designated Zoom link for all of our seminars, will be used. And this will also be shared out through Facebook and other platforms. Thank you, everyone, for your participation. Thank you so much, Dr. Danielson, for continuing to speak out in defense and in support and in empathy of just so many people who are struggle in various ways because of having experienced, you know, multitudes of adverse childhood experiences. Enlightening presentation and inspiring as well. So encourage attendees to take what you've learned and apply it in your sphere of influence. And thank you so much for being a part of our seminar today. Goodbye.
Thank you so much.